So I'm going to talk today about a somewhat narrower topic, coming to a more narrow focus from some of the broader over and encompassing discussions we've heard this morning. I'm going to talk about the treatment of opioid addiction in this special target and very vulnerable target population of adolescents and young adults. And I'm going to start with a little bit on the scope of the problem, but I won't belabor that. You know how terrible this current scourge is that affects families and youth, and people are dying across the country, and so I don't have to spend a lot of time talking about how terrible it is. What I'm going to focus on is an emerging model of care, an emerging approach that incorporates known tools from the adult treatment field and is learning, slowly unfortunately, but nevertheless learning with encouraging results, about how to adapt and adopt these tools into more developmentally informed treatment for young people. And I'm going to focus my remarks this afternoon on medications, but I want to just preface that by saying it isn't because I think medications are the only or the best or the necessary treatment. It is because they're what are relatively novel, I think, in the emerging research and emerging consensus about a treatment approach, and have not been broadly, I think, fully thought out, and the research isn't clear enough yet to really inform future directions. But I just wanted to give you a taste of what research there is so far and what some of our current thinking is about how to move this field forward. So just to show you a couple of glimpses of why we need to care about youth. Well, first of all, it's obvious we need to care about young people because they are the beginning of this developmental disorder, and we think about addiction as a developmental disorder with pediatric onset, with progression over the lifespan. And the earlier we intervene, we think, as in all disorders, the better we'll do before the acceleration and the consolidation and the severity of the disorder is more towards its end. But here I just want to show you the disproportionate involvement both of young adults and adolescents in highest per capita prevalence for non-medical use of prescription opioids. You see that young adults followed second by adolescents. Not that there aren't plenty of older adults, and by total absolute numbers, because of an aging demographic, there are more older adults involved, but proportionately, young people are involved in this way. And the same is true for heroin. You notice overall the lower magnitude in terms of the prevalence of heroin use compared to prescription opioids. But here again, young adults are disproportionately infected, and that's why we need to care so much about it. But just caring about it isn't necessarily, it's the beginning, and I'm very gratified that the national conversation is, I think, hopefully on the verge of a tipping point. We were just talking after lunch about how exciting it is, maybe a day late, a dollar short, but that people are, I think, finally starting to mobilize resources and alarm into action. So half empty, half full, and that'll be part of our conversation. But I also want to focus on how difficult it is to engage young people and their families, and I'm going to come back and emphasize later families as what I think is an essential part of the intervention, but how difficult it is to engage families in what is a way that will keep them retained, keep them interested in treatment, because after all, anybody who's done youth work, and we've heard about it this morning, and we'll hear more about it throughout the conference, adolescents and young adults are not just short grown-ups, right? They have a whole different developmental set of needs and vulnerabilities and assets, and the question is, how can we make it go for young people? And I'm going to give you a quick vignette of a typical kind of mishmash case. 18-year-old young man comes with the background of having been using prescription opioids since age 15, progressed very quickly to daily use, including full physiological dependence and withdrawal within 8 months, onset of nasal heroin soon thereafter, and progression to full injection heroin 6 months later. And that's very characteristic, right, of this aggressive course of opiate use, the progression of opiate addiction, its pharmacological properties with a rapid progression. He's had some treatment. He's been in residential treatment, including Detox, a handful of times. 2 of those he's left prematurely. 1 he made to the end of what managed care, or as I sometimes joke, 1-800-we-won't-pay, what they allowed to be the ultimate length of short-term stay in a residential setting, but then he did not take the treatment providers up on the recommended course of outpatient treatment and continuing care subsequently, and again dropped out in relapse. He had one outpatient-initiated course of buprenorphine treatment. That didn't go great. It kind of consisted of the, oh, so you're a young person with heroin addiction? Here, let me write you a prescription for a month of buprenorphine and 4 refills and have a nice life. That didn't exactly go great, and he sold some of it and used some of it and continued to use injection heroin and didn't get better. Not exactly a poster for high-quality buprenorphine treatment. And I'll talk a little bit about what I think that high-quality buprenorphine treatment in this target population might look like. But anyway, he comes back to us now, and he says, Doc, I'm at some low. I'm in 6 different kinds of crisis you can't even imagine, and this time I'm really ready. This time I really mean it. I'll do whatever you say. I'll stand upside down naked in the rain if you say so. It doesn't matter. I'm in. What do I have to do to convince you I'm in? But by the way, I'm kind of in a hurry, and there's a big party Saturday night, and I promised to take my girlfriend, and so can we be done soon? Oh, and did I tell you, by the way, that I'm allergic to Suboxone, so it has to be Subutex? Oh, and did I tell you that Xanax is the only thing that treats my anxiety? And no, you can't talk to my mom. Now let's get started. All right, so what are we going to do? And again, I don't mean to trivialize or make fun of anybody's suffering. This is obviously a person in great distress and at great risk of bad morbidity and bad mortality. But I only joke a little bit to say that there are developmental aspects of what it means to try to engage a young person who is at best in contemplation, but maybe in pre-contemplation and maybe in pre-contemplation about where they want to go and what they want to do and how they want to engage in treatment. And you guys know, if you've worked with young people, or if you've parented young people, or maybe some of you have been teenagers, I don't know. But the idea is, you know what some of these vulnerabilities are. Young people who think of themselves as invincible, these eventual harms and consequences don't apply to me. There's this trajectory of maturation or immaturation, which is only part the way done. There are issues of motivation or lack of motivation, and there's an issue which I don't think we talk enough about in the treatment delivery system, about how treatment is kind of unappealing to young people, and that's on us, right? I mean, I get a lot of young people who say, that's lame, I don't want to go to meetings and counseling and treatment centers, I got better things to do, and some of those things include getting high. Maybe that's not what it should be, but we haven't really, I think, made enough of progress in terms of making treatment. Maybe fun is too high a bar, but something between lame and fun, I think we could do better. The burdens of treatment are really considerable. Now, that's true for everybody, but I think it's particularly salient for young people in terms of what they might rather be doing. And then there's the issue of engaging their families and who's paying for it and what the other obligations of people in the family in terms of paying for it, in terms of transportation, all those other kinds of logistical barriers. The issues of family are really important in terms of what families are able to do in terms of the leverage for treatment adherence. And some families have totally abdicated and are nowhere to be found. And then there are another set of families, I think, who knock on our door and don't exactly get a welcome mat. And I hear families complain, and you may have heard this too, by saying, well, listen, I've dropped little Johnny off. I want to hear how things are going. I know that I'm trying to do the best here. And I call up the counselor and say, how's little Johnny doing in treatment? And what do I get? I get this kind of recording that says, we can neither affirm nor deny that a person by that name is receiving treatment at this facility. And I get that confidentiality is really an important value for treatment. I don't mean to minimize that, but, and we'll talk when we talk about family modalities of treatment, where are we with mobilizing and activating and empowering the leverage of families, which I hope we can do a better job at. And then the young people have what is a normative, developmentally expected pushback against what they see as the over-restrictive intrusions of their parents telling them what to do. I'm 18 in one day, and I'm all grown up, and you can't tell me what to do, and Mom, you don't know anything about what this is about, so shut up, this is my treatment. How do we work with what is the expectation and the normative transition from adolescence to emerging adulthood, where we want to promote self-efficacy, we want to promote independent living skills, but These are not fully grown up brains, both chronologically, maturationally, and never mind this history of intoxication and other comorbid disorders. I'm going to run through now a really quick survey of the extant literature on the treatment of youth opioid addiction, with an emphasis on the adaptation of medications, relapse prevention medications, or medication-assisted treatment in this population. And hold on to your hats, because it'll be quick, but it won't be that long, because there isn't that much literature. So we'll go through it quickly. I want to start with residential treatment. And residential treatment is very important as having, I think, a critical role in the continuum at being able to take control and do containment for young people in crisis. But I also want to emphasize that it is not curative, and for too long we have had this idea that you can put young people in a 28-day rehab like you're putting them in the oven and they come out the other end baked and cooked and finished and cured. And that surgical model is clearly ineffective. But the good news is that there is some effect, some very positive effect. Here is data from our treatment center from, I don't know, a couple decades ago, looking at 149 young people, comparing those who got treatment for heroin addiction and those who got treatment for non-heroin using substances. We're looking at the change in the days, or the percentage of days used. And as they come in, this is residential detox, so obviously they're all very severe to gain entry. And after a short-term period of residential treatment, say 3 weeks, at 3-month follow-up, they've all reduced their use in an effective way with a good treatment effect. But then there's the typical check mark pre-post treatment kind of outcome, in which back out in the community, they're not necessarily engaged in continuing care. There's relapse, there's re-exposure to drug-using peers, so there's attenuation of the treatment effect. And the good news is that although there's relapse and attenuation of treatment effect, at 12 months, they've all, or at least in aggregate, reduced their number of days using. The bad news is, you notice that line is still not at 0. And then looking at the treatment effect differentially on heroin users, at all time points, the heroin users are more severe and using more, relapsing more, not responding to treatment as much as their non-heroin user counterparts. So conclusion, heroin use is a really bad flavor of addiction in young people, right? Big duh. But it's important to see, and that there is a role for residential treatment, even though it is not curative. This was the first study in the modern era by Lisa Marsh. She was in New York at the Roosevelt Hospital System in those days, looking at a randomized trial of buprenorphine detox over 4 weeks versus a clonidine detox over the same time period. And at the end of 4 weeks, buprenorphine retained more young people than clonidine. So proof of concept that there's some safety, that there's some efficaciousness, and that at least over the short term, this is not a maintenance strategy, and I avoid the capital M maintenance word in young people anyway, because in teen years, that seems like forever. You know, teen years, dog years, there's some kind of translation that we grown-ups can't understand, but to say maintenance means what for the rest of my life? That's not my implication. Here, though, very clearly, this is a taper over 28 days, short term, with a transition to no medication treatment, proof of concept that buprenorphine gets you something. The next chapter was George Woody's multi-site study in the NIDA Clinical Trials Network. Our center was privileged to be one of those centers, and this was a randomized trial of 12 weeks of enduring, 12 weeks is still short term, but 12 weeks of enduring buprenorphine treatment, and in a research paradigm set up to emulate what maintenance treatment might look like, except that since you can't just stop buprenorphine at 12 weeks, you got to taper it beginning at 9 weeks. So this is 9 weeks of a maintenance dose of buprenorphine followed by a brief taper and then stopping, compared to a control condition of detox only without buprenorphine. And so this is looking at an outcome of opioid positive urine results. So south is good, north is bad, right? And we're looking in the black circles, those in the intervention condition on buprenorphine, those in the open white circles in the no medication control. And during the time they get buprenorphine, they have, good news, lower rates of opioid use, lower rates of opioid positive urines. As you taper the medicine and then stop the medicine, it reverts to control. So proof of concept that while people are taking the medicine, again, it's not curative, when you stop it, it doesn't work, but while taking the medicine, it seems to reduce opioid use. A lot of these youngsters are injection heroin users, but some of them were sniffing and swallowing prescription opioids as well. So that's the good news. The bad news is you'll notice that the aggregate result is not 0% opiate use. And the bad news is that the intervention, unfortunately, is not curative. Not that we would expect it, just like we wouldn't expect an antihypertensive or an anti-diabetic medication like insulin to be curative, but a reminder that what we have here is now proof of concept. I showed you before 28 days. This is now 3 months. Proof of concept that at least for that short amount of time, you can get a safe, feasible, acceptable, and positive result. There have been some secondary analyses about what are the mediators and moderators. That is, how do you know who's going to do well and what are the signs that somebody is doing well? They're the obvious things. If you do well early on, it predicts that you're going to do well later on. If you take the medicine, it's better than if you don't take the medicine. One of the things that's curious is that we looked at mediators based on ongoing use of other substances, because our clinical sense is that if you're remaining intoxicated even on non-opioid substances, that's bad for you. We weren't able to find that in these results, but it's not that they were powered to find that. But I'm going to come back to that because that remains a very controversial and important area of research in thinking about these medicines, which are very specific in their pharmacological effect on opiates, but not broadly pharmacologically active for other substances. So coming back to the impact on reducing or stopping opioid use, but what about other substances, which is a very difficult engagement and motivational nut to crack, especially in this day and age when cannabis, well, that's not a drug, Dr. Fishman, so shut up. So having that conversation and thinking about outcomes in that context is really important. Now, shifting a little bit into the community, this is data from Steve Mattson in Columbus, Ohio, where he's done an outpatient clinic attached to an academic hospital following inpatient detoxification on the pediatric wards and then continuing folks in continuing buprenorphine treatment. This is non-randomized data without a comparison group, but it's more naturalistic and more real world, looking at 100 or so adolescents and young adults over a year's course treated with buprenorphine. So good news is 45% retention at 60 days. So encouraging that in semi-real world conditions, you can do this with semi-real world intervention. I say semi because remember, boutique research with 2.5 average caseload and a lot of extra NIDA money and extra attention is one thing. Now what about in a real life hospital with real life reimbursement again, but this is an academic medical center, so it's still semi-real world. But the bad news is look what happens at a year where there's less than 10% retention and most young people have dropped out. So good news, bad news, but proof of concept that the work can be done, beginning to translate it into the real world. And what are the predictors of retention? The same kinds of things. If you have an opioid negative urine early on, you're likely to be more likely to be retained and more likely to have opioid negative urines later on. If your urine is positive for buprenorphine, that is, you're taking the medicine rather than not taking it. And here, he was able to see that a urine test negative for THC was predictive of good outcome with retention and decreased opioid use. So again, important to see that at least some of the research is verifying what our clinical intuition is, that broadly intoxication it leads to other intoxication and leads to worse outcomes. This is data from Boston looking at a general adult internal medicine buprenorphine clinic, 18 and up. And Zev Schumann-Olivier did a nice thing where he compared the outcomes of the older adults and the younger adults just to look at the variable effect of developmental vulnerability. And at all time points, younger people are not doing as well. So at 6 months, you have about 40% retention. At 12 months, you have about 20% retention. And whether that's good news or bad news, glass half full or glass half empty, depends on your frame of reference. Compared to what we have historically been able to do without medications, this is certainly better, but still, young people are not doing as well as older adults. And so again, it raises the question of what do we need to do to tailor the treatment to be more developmentally specific, to do a better job about engaging young people and utilizing these tools. That's kind of almost the extent of the buprenorphine literature. I told you there's not much. What about extended release naltrexone, right? Brand name Vivitrol, which is another relapse prevention medication approach. If you think there's not a lot of buprenorphine research, wait till you see the Vivitrol research. There's even less. We published this brief case series, naturalistic, looking at 4-month outcomes in the first 20 kids we started on Vivitrol in an index episode of Inpatient Detoxification. And of those 20, 16 got linked to outpatient treatment, 10 were still retained at 4 months, and 9 of those 10 were doing well, but it was a loose definition of well, and not all of them were continuously abstinent by any means. They reflected this kind of usual trajectory of remission, relapse, drifting in and out of treatment, but having them in treatment with improvement in multiple functional domains at 10 months seems to me a good broad standard. This is a naturalistic series from another program in Maryland that we published looking at outcomes of 60-some young adults who were treated either with buprenorphine or extended release naltrexone in a specialty program in which they came after an episode of inpatient detox. They signed up for a medication clinic, so this is a very kind of subspecialty program with a high bar of attendance at psychosocial treatment. Everybody who signs up knows they're coming to IOP for a while, and everybody knows they're going to have to give us a lot of urines, and everybody knows that we're going to be monitoring the heck out of their medication supply. There's none of this, here's a month's supply and 4 refills. They're coming 2 times a week to pick up medicines at best, and at the most they can get is a week's prescription until they're abstinent for a couple of months, and so there's a very high bar. And again, we saw a 40% retention at 6 months, almost exactly the same number that Dr. Schumann-Olivier in Boston got. So half full, half empty, again, depending on your standard and your frame of reference. But the ability to retain 40% of these difficult, chaotic, and high-severity young adults in treatment with either of these medicines, I think is a good demonstration of a decent outcome. I wish for better, but a decent outcome with real-world outcomes. So this is Medicaid reimbursement. This is full caseloads. This is non-research counselors, sweating and doing their best with patients, some of whom have family involvement, many of whom who don't, some of whom are homeless. So a demonstration that there is some translation into community involvement, into community effectiveness, but it's a very small number. And again, it's not the results that the adult literature has shown us, where retention at 6 months is typically 50% plus for a comparable group of adults. So again, vulnerability in young people, and how do we address it? The last study I want to show you gets at one additional element. This is again from Lisa Marsh. Remember I showed you that she had 28-day outcome at one point. This is 2-month outcome. This is Bup for 28 days versus Bup for 56 days. The outcome is at 56 days. Continuing people for 56 days gives you better 56-day outcome. All right, that's one thing. But what's really interesting is, and this was an accidental finding, she started the study asking people to come every day. And that's one of the things you do in research. You want to control every variable. You want to make sure you get high retention. And by the way, we also think that in doing this work, these young people need all this structure and need high dose and need lots of intensity. And maybe they do, but what she found is it was hard to get people to enroll and to retain. It was a lot to ask people. So halfway through the study, she switches to a different model, asking them only to come 2 or 3 times a week. And you have side by side the 2 different models. In both models, 2 months of treatment beats only 1 month of treatment. But the model where we're asking them only to come 2 or 3 times a week beats the model when we're asking them to come 5, 6, or 7 days a week. And so it raises the question, and this is the first study that's looked not just at the medicine effect, but at the treatment delivery, psychosocial component effect. What's the right balance? We want to ask a lot. We think there's a lot of intensity needed. There's a huge need for structure, but this is not a sprint, right? This is a marathon. We think this is an enduring need for continuing care, and what can we sell over time that is the right balance? Where's the sweet spot between burden and effect? And by the way, I don't know the answer to that question, and this research doesn't show us that, but it's at least our first look at addressing that question. Is there something that's less burdensome that over the long time will do better, but still fulfill our need to do adequate monitoring, adequate safety, and ensure effectiveness? Well, as I say, medicine is part of the answer, but it's certainly not the whole answer. So if only it were that easy, right? If only we could do some surgery on young brains and fine-tune the mu-opioid receptor with an ectomy or an ostomy or something like that. But we obviously can't. So I'm going to wrap up. I just want to talk about what we're beginning to get in consensus from those like me around the country who have been specializing in this high severity, high vulnerability target population as a consensus for where we're going and what we ought to be trying. And let me preface this with a caveat that I don't really know. I don't have the answers. This is new work, and plenty of people would criticize it by saying, you're giving what to whom? You know, what about the emerging adolescent brain, and what about the safety of these medicines over the long haul? And this is all new. The good news is we don't have any information that tells us that these medicines have significant side effects beyond what they have in adults, and so giving them to young people doesn't necessarily have additional toxicity, but we have a lot of work to do in terms of thinking about what their sweet spot is for effectiveness. Our model of care is that we tend to engage people at an episode of residential detox where there's so much crisis going on, you need to contain the body to get a hold of them, but that everybody ought to be offered one of these relapse prevention medicines, buprenorphine and or extended release naltrexone, and that includes 15 to 25-year-olds, that they ought to be treated in specialty care that's youth-focused and opioid-focused because there are special needs for young people, special tricks for engaging them, and particular treatment approaches that have to do with opioids in which they're going to self-segregate anyway from their counterparts who are only marijuana and only alcohol using, right? The kids who are younger and using marijuana will look at these guys and say, these are real junkies, they use drugs, what we use isn't real drugs, it doesn't count, we're only here because somebody grabbed us by the scruff of our neck and we haven't suffered. And the older opioid users will look at the cannabis-only, alcohol-only group and say, these are babies, they haven't suffered, they don't know what's going on, we want nothing to do with them. So they're going to separate anyway, and then there's this issue of iatrogenic contamination. I can't prove to you that it's a bad idea to mix them, but the idea of putting a 14-year-old cannabis-only user in the same group with an injection heroin user who's also an emerging pro at the sex trafficking trade, that's probably not a good combination. Again, I can't prove it, there isn't good data, but we don't necessarily want people to, be in delinquency academy or high severity addiction academy. Our model is that everybody gets offered continuing care that includes ongoing medication, that includes ongoing therapy and counseling, that includes ongoing co-occurring treatment with lots of frequent urine monitoring, and that being in the full, holistic, comprehensive treatment program is the cost and part of what you got to do to be able to get medicines. And I tell you, that remains a question. What's the right dose? What's the right requirement? We think it's what people need, but are we putting people off by holding the bar too high? And are there people who we are allowing to remain on medicines, which we do and try to individualize treatment, when their outcomes, their progress, their results, or their treatment participation in other non-medication components is not sufficient? Of course, I don't have the answer to that, but it remains something we've got to struggle with all the time. And I don't have to tell you that these medicines have their downsides. They are not perfect. They're good, but they're not curative. Buprenorphine is divertible. There's all sorts of mischief and monkey business that people get up to, swapping and selling and not taking their medicines. And this issue of other substances is very vexing. So our notion is that the gold standard is full abstinence. That may start with cutting down opioid use, but we want people to use no opioids. And then beyond that, we want people to use no intoxicating substances. And what a crazy idea. Yes, I think that cannabis is an intoxicating substance that gets young people in trouble. But how do you persuade them of that when they say, I didn't come here Everybody drinks. I didn't come here for my drinking problem. I don't have a drinking problem. I didn't come here for cannabis. Cannabis is not a drug. I came here for heroin. Don't torture me with all this other stuff. And how do we engage people over time in a way that is compelling to them, that allows for gradual progression with incremental progress? But where do you draw the line? And where do we say enough is enough? I'm not going to prescribe buprenorphine anymore if you're continuing to ruin your life with these other behaviors that include alcohol, cocaine, Xanax, cannabis, et cetera. Again, we don't know what the right approach is, but it remains a vexing problem in an emerging treatment model. Clearly, there ought to be a combination, but what's the right balance here? What's better, medications, counseling, or meetings? The best I can do is yes. There are some people who need more of one than the other. There are some young people for whom the clear active ingredient is more one than the other, but I have no way of predicting that. So it's a bit of a kitchen sink approach in which let's start with a lot and back off. But remember, as I showed you before, asking too much might be overburdensome for some people. And I just want to show you one last thing in terms of, because I promised I'd talk about families. I don't think we do enough of a job, a good enough job engaging families. I think it's an underutilized resource. In part, it's because of the normative developmental pushback by young people who say, I don't want my families involved. They've been nagging me. They don't understand. They've been busting my chops. I don't want to be in trouble. This is my thing, not theirs. How do we get families involved in a better way? And I think that setting it up as a dichotomy between confidentiality on the one hand and full empowerment of families to run the show, know everything, and be able to tell kids what to do is a false dichotomy. I think there's a way of bringing families and young adults together and getting to yes in terms of improving communication and getting releases of confidentiality and finding a role and a roadmap and a recipe for how they can work together. One idea that I've been very interested in lately is emphasizing medication adherence as a wedge in to engage families. Not that there aren't plenty other things for families to be concerned about, but what we do in the broader psychosocial aspects of treatment are sometimes confusing to people. You sit in a group and you talk about feelings and recovery skills and what's that, and I don't know the secret handshake and what is all this about. But every parent has had the experience, right, of having to wrestle with a 5-year-old that has an earache and doesn't want to take that stupid pink medicine. That's a known conflict for families. Now, wrestling with a 5-year-old who's yay and wrestling with a 250-pound 21-year-old may be different, but the concept of being concerned, of utilizing medical services, of working with doctors, of talking about medication adherence is at least a wedge in. So that's where we've been trying to emphasize educating families, giving them a role, giving them a responsibility. And our latest kind of fun experiment has been thinking about home delivery. And I don't know if it's got legs. We've done 9 cases and we've liked the outcomes. Here's just a picture of sustaining people in home delivery of extended release naltrexone. Those of you who've worked in assertive community treatment in high severity mental illness like schizophrenia, we have ding-dong depot antipsychotic calling. This is ding-dong depot naltrexone calling for young people with heroin addiction. And at least with our first 9 cases, people don't feel it's over-intrusive. People feel like it's a display of concern and caring. I don't know how to pay for it. I don't know if it's scalable, but I think it's an interesting thing. And I'm just going to stop by saying we've got to do a better job. I wish we could find better brains, right, and do brain transplants. But we can, to some extent, if we keep them alive long enough, right? So part of the goal is engage young people, engage families, figure out what tools you can use. I'm advocating for the incorporation of these relapse prevention medications as part of the tool set, not the whole tool set, but thinking about anything that will keep them coming back gets them further along to maturation. But we need to do better because we really don't have a good consensus about an approach to these young people. I happen to think that families are part of the solution. I got to prove that to you, so you'll invite me back in 5 years after we've done the randomized trials. But thanks for coming and your attention and doing what you do.